Hello, everybody, and thank you for joining us back here at Soligenix's channel. We have another special interview for you guys today as we sit here with Dr. Jennifer DeSimone, the Director of Cutaneous Lymphoma at the Inova Scar Cancer Institute in Fairfax, Virginia. Jennifer and I are going to dive into the goals of early treatment in CTCL, or cutaneous T-cell lymphoma, and touch on the potential importance of HyBryte a little bit as well. Jennifer, how are you, and are you ready to get into it?
Hi, good morning. I'm feeling great, and I'm looking forward to discussing some of these really important issues today.
Wonderful. So we understand that there are several goals with early stage treatments. Would you agree that for newly diagnosed early stage CTCL patients, providing simple treatments which achieve excellent symptomatic relief is a reasonable goal?
Absolutely. Particularly in early stage disease, we know that the prognosis in general is quite good. And so you want to make sure that the cure is not worse than the underlying problem. And being able to provide a very simple, low side effect, easy to use therapy for early stage patients makes the most sense.
Yeah, that's true. Well, a lot of treatments, as you said, can be very harsh on people. We've come to understand that preserving their immune status for as many years as possible is like a common goal. Can you walk us through like why that is important?
Sure. Well, I think that's important for any patient in any disease state, but particularly when we're talking about a malignancy of the immune system, which is what cutaneous T-cell lymphoma is. An abnormality has occurred in the lymphocytes, which are the immune soldier cells of your skin. And you want to make sure that that immunity is intact. You want to avoid any immunosuppressant medications in that setting, as again, the origin of the problem is a malignancy of the immune system.
Interesting. And for years, they had used steroid creams and other like topical creams and such as a first choice, but those have a lot of side effects that we've found out over the years, and they're not indicated for first line use. What are your thoughts on people using these long-term steroids?
I think topical steroids are an easy thing to reach for first, particularly when the diagnosis may still be in question, but they really are only safe in the short term, as you sort of alluded to. When you use particularly high potency steroids for many, many months at a time, which is what would ultimately happen in this chronic disease state, you can certainly run into some fairly significant long-term side effects like skin atrophy, increased vascularity, etc. And in general, steroids are providing some local immunosuppression, so not ideal in the long term.
Interesting. Another thing people frequently use is light therapy, right? In early plaque or early patch plaque patients. What do you see as some of the distinctions with PUVA, NB-UVB, and now a treatment which uses a visible light source, which is HyBryte?
So this is important. Not all phototherapy is the same. UVA-based Sorolin pretreated phototherapy is effective because the spectrum of light in UVA penetrates the skin more deeply. So in patients with plaque disease, you can hit your target more readily with UVA. However, there are many side effects to PUVA. Patients have to take that Sorolin pre-medication, as I mentioned, which is what allows the cells to be primed to be targeted by the ultraviolet type A, but it's very difficult to tolerate medication for most patients, a lot of nausea, a lot of fatigue. And then additionally, patients are sensitized for nearly 24 hours around the time that they've taken that, which then requires multiple precautions to be taken just in being outside in ambient light. Additionally, PUVA, we know that after 350 sessions can increase your risk for developing squamous cell carcinoma. We know this after watching the group of patients that were treated in the late 70s and early 80s with many years of PUVA. On about a 15 to 20 year delay, unfortunately, many of those patients developed multifocal synchronous squamous cell carcinoma that are very difficult to manage. So there certainly are both short-term and long-term issues with using PUVA, as we call it. Narrowband UVB, shorter wavelength of light, more effective in patch stage disease or very thin plaques, again, because the wavelength of light is not penetrating down more deeply in the skin. Much better tolerated. You don't have to take any oral pre-medication with that. But again, you're exposing patients to ultraviolet light, which we know is a risk factor for other types of skin cancer, including basal cell carcinoma, squamous cell carcinoma, and melanoma. So again, you have to watch the total amount of sessions that people use for that. And there are some long-term risks as well. Additionally, you can get short-term issues with sunburn, discomfort, things of that nature. Using visible light has multiple advantages. Number one, you almost completely obviate that malignancy risk. Number two, very well tolerated in terms of lack of burning, essentially, which is what you can get from ultraviolet light. And number three, can potentially be used in the long term without many short or long-term consequences. So it's appealing for for those reasons.
Okay, interesting. Can you tell us more about your involvement then with the FLASH trial and working with HyBryte so far?
Sure. So my site was one of the high enrollers for this trial. I run a cutaneous lymphoma multidisciplinary clinic where we have many, many cutaneous lymphoma patients, T-cell lymphoma patients, most of whom are early stage. So we had a large pool of candidates to draw from to offer enrollment into this study. Almost every patient that I discussed it with was interested in giving it a try, again, because of these advantages over other types of skin-directed therapies that we've covered. And we found that patients tolerated the procedure well. There was a lot of convenience for them in terms of being able to apply the pre-medication at home. And patients had a great response. Particularly, I had one patient with very deep follicular tropic disease who had an excellent outcome.
Wonderful. So, kind of wrapping everything up, why might a drug like HyBryte be so important for early stage CTCL patients?
Well, I think it's critically important to try to get this device-based, drug combination available to cutaneous T-cell lymphoma patients in early stages of disease, because we know the disease is chronic. So we need something that is effective, but also safe to potentially be used in the long term. It offers a lot of advantages in terms of avoidance of increased malignancy risk, avoidance of systemic side effects like nausea, fatigue that are involved with other types of light therapy. You don't have any long-term implications that we've been able to identify in terms of skin atrophy or problems that are associated with topical steroids, and there's no evidence of any immunosuppression locally in the skin or otherwise. So I think it's easy to use. It's been shown to be effective, safe in the long term, a very good fit, and should be one of the first things that we can consider when trying to identify the optimal skin-directed therapy regimen for early stage patients.
Wonderful. Well, Dr. DeSimone, you somehow managed to be both comprehensive and succinct at the same time. So thank you for coming on, and thank you everyone for watching. If you have any questions about these topics, let us know and we'll happily dive into them further. But for now, Dr. DeSimone, thank you so much for your time today.
My pleasure. Thank you for inviting me.